The final keynote will be given by Dr. Alex King, the Director of Behavioural Insights at the Behavioural Insights Unit. We're better to be a Director of Behavioural Insights than there. New South Wales Department of Premier and Cabinet. He'll discuss, can you guess, health and behavioural insights in New South Wales. So you know about behavioural insights. They draw on research into behavioural economics and psychology to understand choices and decision-making, and by focusing on the social, cognitive and emotional behaviour of individuals. Remember economics, they just have that very neat idea of supply and demand and how that dictates all human decision-making, and it's not really like that. There are social, cognitive and emotional factors too, and by looking at them, subtle changes can be made to try and nudge people in the direction that you want them to go. Remember I talked about that bicycle company yesterday putting a picture of a TV on the side of their packages, nudge people to behave in a certain way. So, how can you nudge? Let's find out. Please welcome Dr. Alex King.
Thanks. Good afternoon, everybody. And thanks for the opportunity to be here today. Get this working. So I'm going to talk today about the application of behavioural insights to the area of health and well-being. This is an area where we in the Behavioural Insights Unit have done quite a few projects. For example, trying to encourage decrease the number of no-shows to hospital appointments, increase the number of women taking up cervical cancer screening appointments, addressing things like childhood obesity, increasing use of private health insurance, and so on. But today what I'm going to focus on is our most recent work, which has not yet been widely kind of publicised, which is on hospital discharge. So the problem we start out with is, if I can frame it this way, across New South Wales there are people staying in hospital beds who don't need to be there. They are medically ready to go home, but they're not yet been discharged, and they're staying longer than they need to. It's perhaps not surprising. This graph actually shows how long people stay in emergency departments. It's not surprising that those who are admitted stay longer than those who are not admitted, and of course they're sicker and they need more treatment. What's perhaps more striking is that the people who are waiting to leave ED, 41% of them at any given time are waiting for a hospital bed, which of course is not the optimal scenario. So even a fairly small increase in discharging patients can have flow-on benefits throughout the system. It's also better for the patients. Most of them, of course, would rather be in bed or at home. And it's also better for the staff in terms of reducing the pressure on them. Now, of course, every hospital aims to have a well-coordinated and timely discharge process, but I'm sure most of you will be familiar with that. That doesn't always quite happen in process. It's also the case that there are quite a lot of known strategies that will help improve some of those discharge processes. For example, things like daily patient journey board rounding, active demand management, criteria-led discharge, and so on. But what's interesting is that those are not universally applied, or at least not consistently applied, both between hospitals, but also within them, actually, which is, a source of at least some concern. We know it's in the best interests of the patients, the staff, the hospitals, for people to increase discharge rates. So why aren't these being used more widely? And this is where we hope that behavioural insights could help make some progress. I'm just going to briefly leave the hospital there, and I'll come back to it in a minute, I promise, and talk instead about what is behavioural insights, or behavioural economics, nudging. People do throw a lot of different terms around here. But let me give you my version, which starts with the basic principle of human evolution, hopefully to a usually more higher form of life than illustrated here, but nonetheless the process is, we have all gone through evolution over a period of time. And during that process, we have evolved, our brains have evolved to use simple rules of thumb, we call heuristics, to help you make judgments and decisions very quickly and efficiently. We're energy maximizers or optimizers, so the less brain energy you can use, the less food we need to eat, and so on. And these heuristics were very beneficial to our ancestors, allowing them to save energy and time. After all, if you're walking through the jungle and something kind of orange and black moves towards you very fast, you probably just want to think it's a tiger and jump straight out of the way. You don't want to be sitting down on the list and saying, right, what are all the things? This could be item A, could be a tiger, evidence supporting this, and so on. You want to just move. And indeed, many of these heuristics that we use are still very relevant and helpful today. But they can also lead us kind of astray. Now, hopefully most of you will have done the homework that we asked you to do yesterday in order to illustrate some of these principles. Hopefully you remember Doug. We asked all of you the question, would you begin the process of discharging Doug? We gave you all the same information. Doug had come to emergency with shortness of breath, was diagnosed with pneumonia and so on. And there was just one change. Half of you randomly were told 90% of Doug's tests have been complete. The other half, randomly again, were told 10% of his tests are still outstanding. All the other information was the same. Now, of course, that's the same fundamental piece of information, just framed two different ways, so you wouldn't expect there to be much difference between the two. However, there is quite a stark difference between the two. As you'll see, of those of you who were told 90% are complete, 2/3 of you said, yes, start's been ready to send him home. On the other hand, for those of you who were told 10% of his tests are outstanding, 2/3 of you said, no, don't send him home, he's not ready to go yet. It's quite a significant, even with the sample size we're looking at here, this is quite a significant difference. It's an example of what we call the framing effect. It's actually quite well established. It comes up a lot in medical circles. Things like, you focus on how many people's lives you're going to save, how many lives might be lost, can change the way people just make decisions. And generally that's true. A subtle environmental cue can influence our behavior and our decision-making, even when, in this case, it's actually the same information we're providing. And this is ultimately the realm of behavioral insights. Many of you will be familiar with the work of Daniel Kahneman, Nobel Prize winner, who famously described two modes of thought. It's itself a kind of simple heuristic, System 1 and System 2 of the human brain. So we have sort of two modes that we operate in. In one mode, we are in what we call the System 1 mode. It's that realm of those heuristics, those rules of thumb. It's fast, it's effortless, it's quick, it's fairly mindless. The kind of mode you might be in, probably we're in this morning, or maybe not this morning, maybe on Wednesday morning when you went into your normal work, you'd gotten up and just done the same thing you did every morning, gotten on the same bus or train and not really thought much about it. Maybe today, when you were coming in, or yesterday, you would have been in System 1 mode, thinking, well, how am I going to get there? I'm going to think about, work out the plan, how I'm going to get there in the office. Also the same mode you might be in when you're trying to, for example, buy a house or decide where to go on a holiday. You're thinking, it's lists, it's lots of pros and cons, and thinking through your options. Now, your brain wants to use System 2 as little as possible. Some of you may be finding your System 2 shutting down right now and the desire for lunch increases. System 1 is much more efficient. That's where you want to be. That's where your brain wants you to be. What does that matter? Why does it matter? Well, public services are designed making assumptions about human behavior, and one of the fairly consistent patterns is that we have a slight tendency to assume people are using the deliberative System 2 quite a bit more than they actually do. Now, that's just one example of a sort of mismatch between behavior and assumption making. The realm of behavioral insights, the purpose of behavioral insights, is to try to help services and policies fit better to the way people actually do behave, the way we know they behave and think and make decisions, rather than the way we might assume they do. The government has a number of tools at its disposal. Some of the classic ones, things like provision of information, regulation, incentives. These are the kinds of things that naturally sit with that System 2 deliberative, rational kind of thinking model. Where BI comes in is what we try to do is bring in some complementary tools. They by no means replace the conventional tools. Things like defaults. For example, very famous cases around changing pensions from being an opt-in scheme to instead being an opt-out scheme. Massive increase in saving rates. Some of things like organ donation, fairly well-known phenomena. Countries where you have to opt out of the organ donation register have higher donation rates than those you have to opt into. Those defaults send a very powerful signal, and that's something we can use to try and get people to do something that's actually in their own best interests. Process simplification, we do quite a lot of that. In an ideal world, we'd never have to do that. All public services were designed to make it as easy as possible for the user. We know that's not always the case. We also know that even very small frictions can be quite powerful in deterring or encouraging people's behavior. So adding in like an extra one click on your website, one click, you lose something like 2% or 3% of people. So every time you sort of have 4 or 5 steps, you've lost quite a lot of people following through. You see that a lot in the digital space, but we see it in almost every area of public services. A lot of even very small, the accumulation of very small effects adds up to somewhere a big deterrent effect. Messengers. We know who the information comes from and how it's presented, whether you like that person, whether you respect them, whether you trust them, significantly affects how you then respond to that information. If I'd been introduced this afternoon as Bob, some guy I met down the pub, rather than Director of Behavioural Insights, you'd probably be paying quite a different level of attention to what I was saying right now. Similarly, we look at tools like framing. I talked about changing the way we're framing using positive and negative framing has a powerful impact on people's behavior. Commitment devices we use quite a lot. Encouraging people to make goals, to plan for their recovery is a powerful driver of behavior. And just one last thing to say about behavioural insights before we move on. It's not just about the behavioural interventions, it's also about using the tools. So using randomized control trials, fieldwork, qualitative and quantitative methodologies, and so on. Why we pair the two together? Because, as I've been saying, humans are very sensitive to small changes. That makes it very hard to get it right first time every time. Much better to test something out. Back to the hospital. That was the whirlwind tour of behavioural insights. So we know people are staying in the hospital longer than they need to. We know their approach is established to do that. So why aren't we being used consistently? Now, a lot of that's about the systems we have in place, of course. But there are some also behavioural issues we saw. 3 of the most important, and there were many, but I'll just pick 3 off. Firstly, time scarcity. Hospitals, no surprise, high pressure, fast-paced environments, life or death decision-making. What we know from cognitive and psychology and neuroscience is that under that scenario, people would do what we call tunnel, which is to take a very narrow perspective. They focus down on the immediate issue, one single issue. Very hard to get them to engage with the broader, longer-term, wider picture stuff. Status quo bias, another big one we come across a lot. The established course of action is always the easiest and most familiar. It's always hard to break people into a new course of action. And just another one, there isn't an English term for this one, so we use the French term. They call it déformation professionnelle. Makes it sound kind of grand. It's a tendency to look at things from the point of view of your own profession rather than taking a broader perspective. And we know that when, for example, an oncologist or a hematologist or a nurse is trying to take a decision, they will usually make a better decision if you actually bring them together and share that information rather than they try and make it individually. So what did we do? Behavioural Insights Unit, we partnered with the Ministry of Health and a number of other key agents, ACI, CEC, and others, to try to bring that behavioural insights to get those discharge practices moving. And the way we did this was to create something we called a 90-day challenge. And what we did was we worked with 17 hospitals covering almost all the LHDs and almost all types of medical inpatient units. The framing itself was an important part of this intervention, creating it time-limited, making it that sort of challenge mentality, a little bit unusual in this space. It's because we know that affects that status quo bias. It's a way of making it more salient, making it feel a bit scarce, making like, oh, we've got to act now, overcome some of that status quo effect. We also broke it down, a process we call chunking down. What we know is setting people a big goal with a long time frame makes it a bit hard for people to respond. If you make it a series of smaller, intermediate goals, they'll far better react to it. We made use of champions and peers, bringing on that messenger effect I was talking about, using LHD chief executives, general managers to visibly sponsor the piece of work, clinical champions, bringing on that kind of peer-to-peer effect, things like peer-to-peer teleconferences, mentoring, sharing experience, kind of selling to each other rather than us selling to other people. And thirdly, provision of feedback. Most of you are familiar with the phrase, what gets measured gets done. Slightly a bit of a simplification, but feedback is a powerful driver of human behavior across many realms. So what we did was we tried to provide feedback to each site on their own progress, data updates. Frankly, sometimes they weren't even getting previously. Sometimes clinical staff, as you're probably aware, don't always have access to their own data. And we try to draw on that power of social norms, to think what other people are doing by sort of sharing what was going on, where are other people up to, what have they achieved so far, wouldn't you like to try and go a bit faster and better? And in terms of what they got them to then do, again, what we actually did was we gave them a sort of suite of potential existing strategies and encouraged them to think about the local application of that, or in some cases to modify and improve upon them. And again, so there were many as part of this, but I'll just pick on 3 that were perhaps most interesting to use. Team huddles around the journey board. This combats that kind of déformation professionnelle I was talking about, bringing the whole team across disciplines together to make a decision about when to discharge a patient, sharing information and so on. Shifting the frame to wellness rather than sickness. Doctors naturally focus on the sick. Encouraging them to come in thinking about who's almost well, and it just changes the way that they can interact. Similarly, patients themselves often seen as quite sort of passive subjects, a recipient of intervention, trying to encourage them to be more active participants in their own wellness journey, using things like patient passports or rehabilitation models that involve setting goals and breaking them down, can make them more active in responding and therefore get well quicker. And thirdly, dedicated discharge doctors. combats that kind of time scarcity stuff I was already talking about. Having a dedicated doctor coming in, principal weekends, where we know discharge rates tend to drop a lot, and they can just really focus on who's almost ready to go home. How do I get them to go home? Whether that be a sort of senior doctor actually making the decision or a junior doctor just thinking about what do I need to do. Either way, a dedicated focus on doing that. So the project, that's all I'm going to say about the project for now. It wrapped up a couple of months ago. We were really pleased with the level of engagement with across the health sector, with all the hospitals we work with. We know a lot of the hospitals we work with did adopt new practices. We don't yet know whether those new practices have actually improved their discharge processes or ED waiting times and so on, so we are evaluating it. Do watch this space, because we will be releasing a report sometime around the end of this year or early next year. I just really wanted to end up by big thank you to all the people who did participate in the process, especially to our project sponsors, Susan Pierce and Brad Astle, and the system performance support team, but also all the other people we worked with through the process, who we worked in close partnership with. And just to leave you with, if you are interested in behavioural insights, its application in health, other projects we've done, please do take a look at our website, bi.dpc.nsw.gov.au. You'll find a range of information there about the work we have done. So when we do publish this report, it'll be on that website as well. And I think that's out of time. So thank you very much for your time.